Good morning, everybody. So anyway, to give you a little bit of my background and how I got here, I'm a family medicine physician, born and raised in San Diego, part of a healthcare delivery system called Sharp Healthcare. And I was born in Sharp Hospital. Went to undergraduate medical school and residency at University of California, San Diego. Joined a physician-owned practice in 1994 and was appointed to a leadership position in 2001 when this group, in a very competitive landscape in San Diego, California, was in the 6th percentile for patient satisfaction, was in litigation with our hospital regarding revenue split. We had physician turnover, despite living in America's finest city, approaching 20%, and 3 consecutive pay cycles where we couldn't make payroll. Outside of that, things are going well. And we had launched this organizational change effort to say, we as a physician group must be better in this landscape to maintain our vibrancy and vitality and even our independence. And so we launched this effort that we call the Sharp Experience, dedicated to making a better product for our patients, a better place for the physicians, and a better place for our staff. And I was appointed and responsible for engaging and enrolling our physicians in coaching and training our teams to be able to execute this change and innovation. And had no idea what I was really supposed to be doing, and really have spent the last 15 years as a student for how is it that we engage and enroll physicians to leverage our influence to create transformative impact. And very proud to say that over the next 15 years, we were able to take our patient satisfaction from the 6th percentile to the 93rd percentile in a national database. We were able to reduce our physician attrition from almost 20% to below 4%. We were able to take our margin from thin to double digit, and we're able to grow our group organically substantially over that time, and 10 straight years of market share growth and 12 straight years of physician engagement improvement, a Malcolm Baldrige Award, a national award for clinical quality, as well as a number of recognitions for transformative turnaround. And people ask all the time, well, how did that happen? How did you go from trough and nidus to peak? And absolutely 100%, it was the active participation and the leadership of our physicians who, back in 2001, when we began this journey, were backseat, kicking the ground, throwing rocks at our hospital, complaining about the misery of medicine, to front seat architects, innovators, and advocates and champions, and leveraging, again, our influence to mobilize a unified team to do extraordinary work in partnership with our administrative leaders. So here today, we're going to give you the sauce and what we've learned in terms of how is it that we navigate change and innovation. So first of all, congratulations on the extraordinary thing that LUGPA has done. I've had a chance to see groups and membership organizations that advocate at a policy level, at a group support level. I have never seen the registry of impact that LUGPA has had on the practice of independent groups in urology. So congratulations. It was breathtaking to see, and I think a real voice for independent physician practice. So interestingly, as we look at what are the key elements in terms of getting this work done, I want you to think about a question. If we were to think about what is present in organizations and groups in independent practice, urology practice, or any group for that matter, it could be cardiology, it could be general surgery, it could be orthopedics, it could be an independent practice group. What is present in those groups that makes those groups vibrant, controlling their own destiny, and managing and becoming everything they want to be? There's very defined, specific things that they have accomplished. They optimize revenue. They manage their bottom line. They retain their talent. Patients love them. We know that it's 10 times more expensive to go get new patients than it is to keep the patients that you currently have. They have a premier reputation among the surrounding networks as this group in particular. They provide extraordinary care to our patients, because I got to tell you that as a primary care physician, if a patient comes back to me from a specialty referral and says, you know what, Nurse was kind of rude, magazines were outdated, physician was very distracted. I tried to call back for my results, I never got any call. I'm not making that referral again. And so the process of having a premier group, there's a very, very specific set of things that are the targets of our change and our innovation to achieve those elements, to manage top line, bottom line, have a community reputation among physicians, among patients, to retain your talent, knowing that it's 2.5 times more expensive, 2.5 times the annual salary of one of your lost staff members if there's a cultural element that prevents us from maintaining our talent. So the learning objectives for what we want to be able to accomplish here today is describe the impact of change and innovation capability on maintaining group vitality. You know, our ability, there's a great quote from, I think it was from Darwin. It says, the ones that survive are not the strong or the smart, it is those that have the ability and the capacity to confront and manage change. And certainly our ability, our agility in this insane healthcare marketplace that we're in right now, we've got to be able to leverage, again, our influence with effective leadership to manage change and innovation effectively. What 3 actions can we take to create big change where we are? And that is, what innovations do we want to do, number 1. Number 2, our ability to apply change management to execute that change. And number 3, what leadership skills are present in groups with high degrees of change and agility and innovation capabilities, and outline the power and the paucity of change management. So to tell you a little bit about, again, how I got here, I've considered myself full-time in the trenches, behind the exam room doors, seeing patients all day, every day, but have more recently had an opportunity to meet with healthcare systems and organizations. Ultimately, how do we leverage physician influence to transform healthcare, to allow clinicians to experience the life that we should? Because healthcare has been under assault in what we believe to be the most sacred, beautiful, unbelievable profession for which we have sacrificed so much to get here. I mean, if you look at the sacrifice of clinicians to get to this place from high school and undergraduate, I remember there are so many things that I missed and didn't go to. We sacrificed financially, personally, professionally to get to where we are. An announcement, this is it. This is everything that we've sacrificed for this band of time, this little moment of time, these 20, 30, 40 years in clinical practice. We got to make it extraordinary. And the things that are happening in healthcare right now are distracting us. And we believe and have a strong sense and good data that the very best of medicine that drive physician contentment and influence and success are still there for the taking. And if you look at some of the things that are happening now, and what's happened as a result of the forces that have come and occurred as a result of a lot of the changes in healthcare, last year it's estimated that 1 million American patients last year lost their physician due to physician suicide. Again, this profession that we have, this calling that we have, where we have 20, 25 times every single day to make a meaningful impact in the lives of others, the top 2% of all earners, there's virtually no unemployed urologists. I mean, you can go wherever you want. Societally still respected. The endeavor and the mastery of diagnosed treatment and learning and continuously improving. So we take this composite of extraordinary things that is the life of the physician, and we get, it's like, how has this happened? So we look at, what is it that we can do to not only change and innovate and create high agility, to create the sort of practice attributes that allows us to maintain our own destiny, whatever that may be, but how do we create the sort of experience that we look over our shoulders at the end of a day, week, month, year life, and we say, man, it has been worth everything. Every sacrifice we've made, every dinner that we haven't been to, every graduation that we weren't able to attend, every birthday party that we couldn't quite make it to, man, it's been a great run. And there's a great neuroscientist from Duke University named Mark Leary who did a fantastic study on what are the big drivers of human contentment. And how does that play into our lives as clinicians? And he found 3 basic fundamental drivers of human contentment. And driver 1 was mastery, our ability to accomplish, achieve, improve, and advance. There's a reason why a great golf shot feels good. There's a reason why learning a piano etude feels good. I mean, we're not piano players or professional golfers, but doing things well and accomplishing, achieving, learning, progressing, contributing, that mastery journey is a fundamental driver and encoded in a predictor of human contentment. And the second driver of human contentment is authenticity. We are living our lives in accordance to what we know to be right. All of us have a code inside of us, well, hopefully we do, of what to do and what not to do, and the do this and don't do this, the things that we hold most dear, influenced by our culture, by our parents, by our peers. We have our code, our map, and those that are living fulfilled lives are living in accordance with that. I am exactly who I need to be and want to be and should be. Authenticity, so mastery and authenticity. And the third domain of human contentment is belonging. We are not designed to go it alone. So groups that are successful, that change and innovate and create and control their own destiny have a strong sense of collegiality. Our data on the prediction of collegiality on groups' agility, change management, innovation is profound. And if you look at the morbidity and mortality of loneliness, it's equivalent to smoking nearly a pack per day. So if we look at what do we embed in practices that allows us to change and innovate and become and have the practice attributes that allows us to maintain our independence, we have to create practice conditions that allow us to pull these three levers of continuous mastery, improvement. We are always changing, always innovating, and we use change management to get this stuff done. We allow clinicians to be exactly what they envisioned. I don't know any resident at the end of when they finish residency, they go, man, 20 years from now, I want to be super cynical, negative, clinically depressed, and difficult to be around. I mean, we don't want that. We want to change. We want to exercise influence. We want to practice, innovate, and we want to make a difference in the lives of patients. We want to teach others. We want to do all those things that are doctoring, and allow us to do that. And we want to build a collegial in this together, like a family, esprit de corps culture in our groups, because that, if we're a family in that group environment, you can do anything. So what do we do? So we have significant belief that we build practice conditions within our practices that allow us to exercise the best and see the best and experience the best, not only in terms of maintain our own vitality and independence by virtue of what we're able to bring to the marketplace, but equally important is we love being a part of the team. And Sunday night before clinic, we're going, yeah, I get to go to clinic, as opposed to Sunday night going, oh my God, I can't take one more day of this. We don't want to be ticking the time clock to say, I just can't wait to get the hell out of here. I mean, God, what a tragedy. You know, this sacred profession. So what do we do and how do we manage this and what are the things that, if we say we want to be able to have the capacity to change and innovate, and we're going to talk about strategies to change and innovate, what do we need to accomplish? What are the things that allow us to maintain that independent vitality and practice independence to control our own destiny? Because if we're going to change and innovate, yes, there's clinical innovations, and you know more about that than I certainly. And we have to continue in that principal stream. We have to have clinical excellence by data-proven measures that patients do well here by virtue of established clinical markers. Clinical excellence is a fundamental predictor of group vitality. But your patients, again, have to love you. And again, our ability, we're getting referrals from outside networks, we're getting referrals from groups, we're getting referrals from partners, and patients' loyalty and what patients say about you. 87% of patients now will look you up before they see you online. So our ability by which to create a consistent, reliable patient experience is critically important in terms of our practice viability. If patients are walking out and posting on you, there is a wave of consumerism. And we can try to suppress it, ignore it, roll our eyes at it, but we got to build a consistent, reliable patient experience. And our clinical efficacy is going to be impacted by that. There was a study that showed that Patients who rate their physicians in the top quartile of trust have about a 70 to 75% participation in a treatment recommendation. Those patients that rate their clinicians in the bottom quartile of trust have about a 15% probability of participating in a treatment recommendation. So again, patients loving you and building that and knowing that our relationship with the patient and what happens in that exam room is a strong correlation to physicians' love for the game. And all of us recall our best clinical moments, the best relationships we have, and go, it's when we get to know, when we impact the relationship, and we're connected with the patients that we serve. So certainly it builds marketplace loyalty, and it creates our sense of love for the work that we do. We want to be a talent magnet. I was working with a cardiology group in Iowa, and they were building a center of excellence, and they were having a hard time with staff turnover, and it was destroying their bottom line. Again, it's very expensive. The high turnover is expensive for a lot of different reasons. And so I went with the cardiology group, and I said, tell me about your staff. And they said, there's about 18 of them in the room. They said, well, they're leaving. We have a high turnover. And I said, no, I realize that. Well, tell me about them. He said, well, they're not staying. They're quitting. I said, I know, I get that. I said, but tell me about the staff. He said, well, we just can't get them to stay. They're you're not getting it. I said, tell me their names. Not one cardiologist could name one receptionist in their organization. They came in the back, receptionists came in the front, there's a nursing station in the middle. Our ability to be able to create a place that is a family. I always ask people what is your group culture like? Do you celebrate the birthdays of your staff members? Keeping and retaining staff is a vital predictor of our ability to get the work done. Clinical excellence, reputation. So any physician within the network said, man, we send our patients there, man, we get a great note back. I'm always aware of what's going on. They are a partner. They'll call me. They'll teach me. That group is fantastic. We're conducting a study right now, and not to release the results early, but shows about 70% of primary care physicians, when they refer to a specialty outside of a fully integrated group, 70% of the time, they have no frickin' idea what's happened to their patient. So building process, so we talk about change and innovation, about there's lots of substrates. The end game of change and innovation is excellence in the patient experience, excellence in team dynamics, excellence in clinical performance, excellence in practice efficacy. Those are the outputs of change management. And innovation ultimately is asking the question, what if? What if we were to do this? And to continually ask the question, what can we do better? What can we innovate? And what can we change? And if you look at the body of literature in terms of how innovation occurs, rarely the most uncommon form of innovation is thinking of something brand new. The most famous of which was flight. Flight had never occurred before. That was an example of an innovation of a brand new. Everything else is thinking of things and doing things better. For example, if you go, gosh, how might we increase revenue without having to see any more patients? How might we increase revenue without having to see any more patients? That's a question that an innovative team would ask. And an ability by which to create innovation and to have ideas that can spurn by asking questions. Anybody have an idea as to how we can increase revenue without having to see any more patients? Simple answer, there's a lot of different things. If we had a whiteboard here, we would pool it to the team, your entire team, your practice team, to suggest ideas. And the clue is 80% of the innovations that occur don't occur by virtue of the principal person that's responsible for that practice, i.e. the physicians. All of our innovations that have occurred in our group, the mass majority of them occurred by our receptionists, by our nurses, by our administrators who have a different angle to be able to execute and create a substrate for innovation. So if we were to pose on a whiteboard, how might we increase revenue without having to see any more patients? Give me an answer. Yes. Give me another one. Yes, give me another one. Extenders, yes, give me another one. Clinical documentation practices. Our group increased revenue by nearly $20 million by coaching and training physicians on how to better document. You can run the treadmill faster, or we can actually learn how to clinically document. So the point being is that our ability by which to innovate, every innovation that emerges is by leaders and members of the team asking these questions. Again, simple things to build change and innovation. And great practices, you see, great practices. Patients love them, surrounding medical groups, they're clinically excellent. They follow up with the primary care referrals. They manage top and bottom line with really good stewardship. There's a set of things that they do. To get and achieve those things, we have to change and we have to innovate. Simple things that we can do. So I looked at my notes. These were just a couple of example innovations. And again, these are many of these you're already doing. But from surgical groups that I've worked with over the last 8 weeks, looking at my notes, because most of the innovations, and again, the fact that we've got this network here for innovation ideas for common practice challenges, what a great opportunity to source and exchange ideas and to crowdsource solutions. I mean, so these are just a couple of things that I've seen personally by virtue of working with surgical groups across the country. There's an orthopedic group that was using this My Health Tracker app for postoperative care. And what it was they could track postoperative care with a little avatar based upon the most cutting-edge postoperative management, where an avatar of the physician was providing day-to-day, moment-to-moment instructions. The physician wasn't doing anything. It was a clinical postoperative protocol where the patient was constantly, the patient felt as though the physician was texting them with prompts and what to do and what to look for and how are they doing, how are they feeling, and managing that data set to reduce readmissions, reduce complications, and blow the patients away. So it's an innovation. So how can we do better postoperative care so our patients are getting better quality, lower risk, lower readmission patients, so the patients say when they come back in, we're dialed in, we're fully connected, and thank you so much, team. You guys are unbelievable. I'm going to go to work and say, do you know what happened to me postoperatively after my prostate? An innovation. Pre-op calls the night before from a surgeon. I just met a breast surgeon in Phoenix. And she says, I just call every single patient before their surgery. They're worried, they're nervous. The call takes 2 minutes just to see if you have any questions. To be able to create and craft a signature. What is your group known for? Creating things that maintain your independence is about being extraordinary in the eyes of patients and those that refer to you and the community at large. They said, that group, holy smokes, they call me the night before my surgery. Every single, and then I get this, they're with me, they help me post-operative. I get this thing, they talk to me on a regular basis, and they've got a call, and then I can, home nurse for post-operative care. One surgical group, a general surgery group, they just send a nurse out to check on every single patient, whether they're needed or not, to build a relationship, to make sure they're okay, to answer their question, to partner with them, to collaborate with them, to make sure they have their social network, all that sort of thing. Thank you notes to all primary care referrals with rich, detailed consultative guidance. I added that one. But it makes a huge, there's a plastic surgeon in our community, Dr. Gupta, and he sends such great notes. And not only do I regularly recommend him, but let's just say all of my wife's friends know Dr. Gupta. And the nidus for that activity was his decision to say, every single referral I get is a gift, and they're going to get a really nice, grateful note. We get a box of candy at Christmas, and again, it's not about that, but it's about the quality of the care that we get and the communication, collaboration, and partnership and coordination of care is immensely important. A innovation would be to say every single one of our primary care referrals that comes to us is going to get a really, really great note. And we'll make sure that we're in coordination, working together on behalf of the patient. So when we're thinking, where do we send our patients? They're going to advocate, they're going to say, this Boston group, man, they're unreal. They're absolutely going to go there. And again, we get feedback that is not like that, or we get no feedback at all. There's just no loyalty. Telehealth post-op visits, again, you're going to hear lots about that. Super MA scribes in the exam room. A lot of what you're going to be able to do is build a practice environment where these new residents that are being offered 15 different places are getting recruited like you can't even believe, and building a place that is unique and special, highly collegiate. We're like a family, really successful top and bottom line. We hang out together, we support each other. We have a monthly meeting at a local craft brewery, and we're like a family here. Those cultural dynamics is a recruitment lever. And to have practice operations to say, here we have scribes. We realize that you getting home for dinner is an important part of the quality of life that you have. So we have scribes to make sure your chart closure times are good and you've got a balance and a quality of life. Scribes have been shown, done under the right circumstances, better notes, better engagement of physician to patient, earlier chart closure times, fewer clicks after 5:30. And to be able to build, so these are examples of innovation, post-consult calls to patients to check on their questions and their clinical status. This is one group where every time they had a new consult, sometimes the clinician would call the next day just to make sure all their questions were being answered. So anyway, so 3 quick actions. 3 things we can do to be able to stem and create innovation and change. And much of the innovation is taking what you do and doing it really well. So patients love us, staff love us, we can recruit top and bottom line management, clinical excellence. And find an innovation that you're passionate about and get it done. And I think the stemming of this, in asking the question, how might we, and this idea of how it is that we do this stems from your story. What is your group's story? What are you known for? So as we create and craft a story, if your story is extraordinary service to our patients, clinical excellence in all we do, and a practice environment that is like family. So if that is your story, that is your North Star, your stake in the ground, and then all of your innovations will say, what change and innovations can we have to execute against our story? Because we don't randomly select things, we do things intentionally to achieve our vision for what we want to be known for and to have everybody know and understand what it's like to be able to have a clear and specific, resonating, connecting story that allows you, if it's executed upon with quantitative measures to prove it, that patients love you, referral centers love you, clinical excellence, stewardship, top line, bottom line management in a practice environment where people say, I'll work less to stay here. Because I love our group and our ability to think of innovations and continually challenge the teams by which to get this work done. So number 1 is to think of innovations and continually challenge the team. And to give you a real quick example of how that can play out, we recently as a group found out that a competing medical group lost a contract with the California Teachers Union. And we had a bolus of commercially insured patients coming to our physician group in short order when our ability to get them in was very, very limited. We had real access challenges. So we had several thousand patients coming into our system that were not very happy because they lost their ability to see the physicians that they had seen before, and we had to get them in. So we had a room full, innovation room, a war room of our receptionists, our physicians, our administration, and nursing in together, and we wrote on the whiteboard our target, get these patients in and wow them. That's our North Star. Let the innovations begin. And none of the innovations, again, came from physicians. It's just because it's part of the innovation center is lowering power authority gradients, and everybody's voice counts and matters, and everybody's actively contributing to serving that, getting our patients in. The 3 innovations that emerged from that is our receptionist team said it would be really great to know if we knew who those new patients were. So from that, we developed a new patient folder. So when a new patient comes in, they get a little blue folder that has a bio and a picture of their selected primary care physician and their story, a little stat sheet on the physician group and kind of what we've accomplished and what we've achieved, and they're with the best now, and a little just what you need to know about our group. And so the other benefit is everybody's walking around with a little blue folder, and our security, our administration, our nursing, our physicians, if they see somebody walking around, we welcome them. Hey, welcome to the group. Get the little blue folder, to this day being used. There's many other groups that have just copied the little blue folder. to identify, to make a first impression. You've got a very short window to make a first impression. The other thing that emerged from this was that our physicians had very little access in terms of our ability to see patients. So one of the nurses said, hey, in the group where I came from, we used to do group visits for some of our chronic disease management. So we developed group visits in time managing diabetic patients where one physician, one nurse, and one diabetes educator could see 10 patients at a time in 90 minutes, radically increasing our productivity. And what happened with those 10, 12 patients, all of which have the same diagnosis, and their idea exchange, their friendship, their fellowship, their mentorship, and what it was like, our disease metrics improved radically, our productivity, and it reduced time burden to allow spots to open up to improve our capacity. The other thing that emerged from that circling that target on the whiteboard was after visit phone calls. We wanted to be able to call patients after they saw us the very first time and to say, how did we do, and do you have any other questions? And now we use it to identify and follow up on patients that are sick. We see a patient for an asthma flare, we give them Solumedrol, and we call them back the next day, hey, it's Dr. Beeson, just want to see how you're feeling. They're blown away. And we've tracked and monitored what that's done for retention and patient experience. So the example is sometimes we have circumstances in sourcing the crowd to say, how do we tackle this, and our ability by which to get this done. So action number 2, I'm going to move quickly. Action number 2 is applying change management. He who has a compelling enough why can overcome anyhow. Our ability to manage change. Anybody know what the success of change is? So if we identify an innovation and we say we want to be able to do this based upon achieving our story, we've sourced the crowd on a really great idea. We've got to apply change management to be able to get that done. But the failure rate of change is 70%. 70% of all changes just fail. They fail. The reason for failure of change is we don't apply change management to the change. Change management is the other strand of DNA for change itself. So we as leaders have to understand how it is that we execute change. We can't just say, let's go do this and tell people to issue it. There's a specific set of sequences of best practices for steps in change management. Our research that we've done show that physicians' perception of change management, about 45% of all leaders in healthcare are ineffective in managing change. So a very quick summary on leading change and the different steps in managing and how is it that we articulate a change. Number 1 is creating urgency. Telling the story why we've got to be able to get this done using data and story. Don't carry around a regulatory banner and say we have to do this because CMS says so, because that is a disengaging call to action. If we look at the things that are most profound in terms of mobilizing people to be able to get things done effectively, is telling stories of patient impact and coupling that to data and using the data and story as a mobilizing force to be able to get the work done. Most effective I saw recently was a chief of staff to a medical staff in a community-based hospital trying to reduce their C. diff and improve their hand hygiene. At the medical staff meeting, this chief of staff interviewed the daughter of a patient who had died of complications of C. diff. Directly attributable to the hand hygiene practices. And she spoke about that patient, what he was, who he was, his hopes, dreams, aspirations, his history, and his network, and what he wanted to be able to do in this world, and what it was like to die that kind of death. They created urgency. And in that context, then they shared their data and their hand hygiene data, which was embarrassing. And they used the leverage of step number 1 of creating change, creating urgency through story and data to say, we got to get this done. Our ability to apply change management is key that the innovation actually gets done. Innovation is famous, the most published word in business literature, and it is known by industry experts to be the most likely talked about and the least likely acted upon. We have to apply change management, crafting a destination, a future state, what we aspire to be, communicating the change on a regular basis. We just went through a change for reducing antibiotics in our urgent care network. We found that 50% of our patients going to urgent care were receiving an antibiotic. When they went for similarly coded upper respiratory infections, they were getting antibiotics in primary care about 15% of the time. So we launched an innovation to reduce inappropriate antibiotics. That's patient harm, that's cost. That's a whole bunch of reasons why we don't want to be able to do that. So we created urgency around this through story and through data. We crafted a destination. We communicated change. We measures of success in terms of quantitatively, how will we verify getting this done? We report our progress on a regular basis. How are we doing against this? How are we doing against this? How are we doing against this? We celebrate the changes. Appreciation and recognition and celebration accelerate change efforts, and if you habitually ignore it, it's the best way to diminish high performance and train the change. In our case, we had to be able to coach and train physicians on how it is that we manage patients' antibiotic requests. That's a very, very specific set of skills that I guarantee you nobody's learned in residency. Beyond the scope of this morning, but looking and thinking about that change management is a really important leader skill to be able to take an innovation and to be able to apply it and execute it where you are. And lastly, the third action is leading really, really well. Leadership has consistently been shown the greatest predictor of our ability to execute against change. Over and over again. And one of my favorite quotes, it was sort of implied earlier, is that great leaders will lead as though no help is coming. Let's go, let's get this done. And our ability to manage and do this. So the question is, the other great guidepost for leaders is that we speak as though the patient and family are at our elbow. If you're committed to doing the right and best thing for the patients that you serve, and that's authentic, and you don't see patients as some necessary substrate for revenue generation and a procedure, we can't have that as our MO. We have found in our research that when physicians are a part of a group where the commitment to what's right and best for patients is felt to be authentic and real and verified by the actions and words of leaders, physicians in those circumstances have a 4x reduction in burnout probability compared to organizations where the culture is, well, I guess we have to see patients to make our top and bottom line. So our authentic commitment to that effort. So here are leadership skills that require no skill, no training, that are just the basic foundations of those that are able to facilitate change and facilitate innovation. They do just very, very basic things to be able to get this work. Being on time, work ethic, effort, body language, energy, attitude. There's nothing great in this world that has ever been achieved without passion. Indifference is the recipe for failure. And if you look at those that are innovating and creating dynamic change and the composite of group attributes, patients love you, staff will drive further just for the chance to work with you. And everybody they care about say, you got to work here. This place is fantastic. And the referring physicians say, wow, that group, clinically astounding, and great feedback from them, and really disciplined top and bottom line management by practice operations. All of those things are necessary, but they're led by leaders who do this. And lastly, the composite of leadership attributes. And you're going to have additional talks. John Maxwell does a fantastic talk on what do we do to lead. But what we found consistently is that the leaders that are navigating innovation and change do very consistent things. They model what we want to become. People see us as ambassadors for all the things that are our target future state and our story and what we seek to become, that we facilitate and tap the ideas of those around us. They will, as surgeons in the OR, they will say to their teams, if anybody sees anything at any moment that could be of risk to the patient, we want you to speak up. And our ability to tap and innovate and crowdsource ideas to be able to create a field of innovation. If we say, I'm the doctor, you're the receptionist, shush, do you know who I am? Our ability to unleash the ideas and the innovations and the contributions of people that have different perspective, different angles than us, and we worked collectively as a team with the lower authority gradients and pool the ideas, and community intelligence is a key substrate requirement for true innovation. Just like we put that idea on the whiteboard, we've got to get our patients in, we've got to wow them. The best ideas came from our nursing and our receptionists. And physicians were facilitators of that, inviters of that we appreciate others. 93% of all recognized behaviors are replicated. In terms of building and creating culture, physicians, leaders that say to their nursing staff and their administrative dyad partners, man, I just want to thank you for all that you've done to help make us better together. I guarantee you try that Monday morning with your receptionists and watch what they do. Talking about reducing your turnover to nothing by virtually spending nothing, and those physicians that are recognizing and appreciating people for real specific contributions that they've made is really great for them, but it's also pretty great for us. I was training a surgeon, probably 4 or 5 months ago, that was having difficulty with nurses on the med-surg floor, and the intervention was just simply thank and recognize the nurses for doing good work. I asked him, I said, do the nurses ever do good work here? He said, yeah, all the time. I said, do you ever recognize them for that? And he goes, well, they're doing their job. I said, try recognizing them, see what happens. He pulled the nurse aside after she had a really effective management of a patient who had a burst of AFib, and did the clinical protocol, called the hospitalist, communicated with the general surgeon, just really communicated with the family, just did a fantastic job. And he pulled her aside and said, you did a wonderful work last night. I just want to tell you and thank you. I know I don't get a chance to do this. She welled up. He called me the next day, and he was troubled that he had been in practice for 15 years and never seized this opportunity. He is now a fundamental, he went to his general surgery meeting 2 or 3 weeks later to say, we need to recognize our staff. It is a culture changer. Recognizing and appreciating others sets the soil for change and innovation. I'm honored, I'm respected, I'm valued, I'm included, my voice counts. The very things that allow us to have the group attributes that allow us to maintain our independence and viability depend upon the granular actions of effective leaders. That we appreciate you. I want to hear your ideas in terms of how we can innovate. I'm going to model the very behaviors that we stand for, that we teach others. Doctor in Latin is teacher. It's you count, you matter. I mean, you think about the best mentors that you've ever had, and they teach and they trust us and they challenge us and they push us. We want to be those kinds of people in our clinical environment to create the composite of things that make for great leaders and great groups. We're out front, we're managing change effectively, and growth mindset. Growth mindset is hope, belief, and optimism. There's a lot of crap happening right now in healthcare and a lot of stuff that will drive us nuts, but if we bring our cynical self and say, we can't, we're screwed, government this, policy that, cynicism's diffusion coefficient is very, very high. You get a cynical, victim-thinking group that we're screwed, good luck changing and innovating. Nobody wants to hang out with that, and it doesn't change anything. So our ability to say, yeah, how do we learn from the things we've done before? How do we mobilize as a team to create something extraordinary for our patients, for us, and to blow the doors off so we can control our own destiny? That's how great leaders, and they bring hope, belief, optimism to get things done. So as I close, building a really successful urology group practice, large or small, will be about our ability to innovate, change, and lead, to take on every challenge and create an amazing place for patients and you. And lastly, I want you to think about, this is Ernest Hemingway, if you don't recognize him. And there's a great story about Ernest Hemingway, and some of you may have heard this. If you've had a writing class, you've heard about this, where there was a challenge with bets on the table about Ernest Hemingway writing a 6-word story. And he wrote this story of for sale baby shoes never worn. And it's been a challenge to writers from across the country and across the world about how do you create clear, succinct messaging that people understand and resonates and connects. And I know exactly what it is that you're saying. And I would challenge you with your groups, when you're with a bottle of wine tonight, to ask yourselves in your group to say, what is our North Star? What are the things that we're going to be known for? What will patients say about us? What will our referring partners and what will the people that are part of our family say about working here? What do we want to become, and what's our story? Why do we exist? And what is our value system that allows us to get there? And your value system, if it's real, if it's tangible, and then every member of the team will know exactly what to do by virtue of looking at your values. We will do the right thing for the patient under every circumstance. That guides me. I got it. So again, I think that the opportunity in front of us. This is a really, really important time for independent groups to hit the throttle. The best leverage for controlling your destiny is to create something extraordinary that is verified by the world around us to deliver clinical excellence where patients say, holy smokes, they are the best. Where referring colleagues are saying, that group, they're getting my patients. And to be able to run effectively, top and bottom line with your practice operations and dyadic leadership side by side with your administrative partners, all of which are coalescing around your North Star and our story about what's right and best for the patients we serve. We are a family dedicated to clinical excellence without compromise. So with that, this is, if you have any questions, curiosities, I think you can, I think there's questions that are coming up here. What are the, so let's, let me address a few of the questions, and then I think we might have a little bit of a break afterwards. But if you have questions that you didn't get answered, you can email me. Always very good about this. But I'm going to test our new technology if that's okay. It says, I think some of these may have been. I think these questions were for the prior talk, so they weren't for me. But anyway, I want to thank you for the opportunity for a primary care physician to sit and meet with you. I'm enormously impressed about what this body has done and how it's supported you, and at a policy level and from an engagement level and a resourcing level. It is, again, having seen a lot out there, this is as effective body as I've ever seen, and you should be congratulated for that. Great opportunities in front of you. Get a little substrate for what change and innovation does and how immensely important this work is. But I want to thank you for your time.